We're going to start. First of all, I'd like to greet everybody. I'm sitting up straight in my seat. I'm trying to get my head in the middle of the picture here. And I see a lot of familiar faces. I see a lot of familiar names, and I'd like to welcome everybody. Leaders Connect has been going for about 20 years, and this is a rather interesting turn for us in terms of shifting it to mobile and Zoom type forecasting and broadcasting. So I'm really happy to be able to do this and that the technology is there for us. And like Mel, the idea of having 100 people in one room to do a Friday morning breakfast may not happen for quite a while. So we're looking at ways to adapt. I want to thank Dave Whitner, who's our, Dave, you want to wave? Dave's one of our sponsors, and Dave has, what's the name of your company, Dave? You want to say real quickly?
Yeah, Office Evolution.
Okay. And he rents out space. So I imagine you're also shifting in terms of some of the ways you're marketing and whatever, but it's over a great spot on Eisenhower and State. So look over there. And then Zingerman's is one of our sponsors. Do we have anybody here from Bank of Ann Arbor? Bank of Ann Arbor is one of our sponsors, and I'm very happy to have Bank of Ann Arbor as my bank. And also thank to Mike Cole. I've got some money in that account now that came from the government. So Bank of Ann Arbor delivers great service and helped a lot of people get their PPP money, however it's called. And then also we have Raymond Financial, who's helped us with our getting our income taxes in. So lots of great sponsors. Probably forgetting somebody, but we have anybody here from the camp at North Star Reach? I know there's people that signed up. And that's another one of our sponsors, North Star Reach. And they also have had to cancel their season. This is a camp that supports children who can't normally go to camp because of severe health crises. So I'm going to jump right into the program and turn things over to my good friend for about 20 years now. We track back to when we both were serving in New York City after 9/11, which we thought, my God, nothing like this is ever going to happen again. And then here we are with something happening that we could not have imagined. So my good friend is Connie Doyle, Dr. Connie Doyle, and she's been an emergency physician for years, worked at the state and federal level in emergency management. So Connie, I'll let you introduce yourself a little bit more and talk about, give us some perspective. The format is going to be, I'm going to have 4 speakers, each going to go for 5 to 7 minutes. Then we're going to break into small groups on virtually, and then we'll ask questions. Please feel free to send in chat questions and also mute your mic so we don't hear anything we don't want to hear or have any interference. So go ahead, Connie.
I'm Connie Doyle, and I met Rob when we both had gotten back and were on a panel from 9/11. I'm part of the Michigan 1 Disaster Medical Assistance Team, which is a federal team, and so I've been sent to all kinds of austere places, as well as on the county and regional planning committees. And we've looked at whether this kind of disaster could happen and what we could do about it, including planning on off-site hospital type cohorting of people with a similar disease, such as the TCF center, which was set up, didn't have as many patients as we had room for, but it still is to offload the hospitals. Since I retired recently, I have been in isolation, and that's been very tough on me not to be in the front lines. And I'm following along with everything that people are doing, as well as trying to field the best information to people, because there's a lot of stuff out there that is just baloney. So I think I've been good in that way, and the county committee only meets a couple of times a year, but we're still looking at what can we do together so that all the hospitals are on board and all of the other kinds of caregiving things, including nursing homes. And nursing homes have a group of like-minded people that are trying to plan their venue because it's a little bit different with elderly and now high-risk people. So I'll stop there.
Okay, thank you. And thank you for your many years of service. And I'm sorry about your loss. I understand your mother passed away recently. So tell us a little bit about that.
Well, she was in a memory unit and they had a couple of cases. So the entire independent and assisted and memory units had to shut down, no visitors at all. And they would send us pictures on a weekly basis, but it was much more difficult because my mother couldn't handle phone calls and FaceTime at the time she had moved to the memory unit. So it was pretty difficult for all of us. I think the last person visited in early March, and then both Ohio and Michigan shut down.
And when did she pass?
April 20th.
Oh, okay, so relatively recently. Well, and how old was she?
98.
Wow, okay. Well, very sorry about that. Not easy time. Was it the COVID or you didn't know it? What was it?
It could have been, there are enough false negatives, but she had tested negative.
Okay.
They moved a bunch of people off her unit and cohorted them in a different part of the care center. So that there was not further exposure that we know of.
Okay, great. We're going to go next to Ginny. Ginny Creasman is relatively new to Ann Arbor, I guess a few years, but she is the executive director at the VA hospital. And Ginny, you want to check in and tell us a little bit about how this experience has been for you and what some of the critical issues that you're facing.
Sure. Thank you for asking me to be on board. I've actually, in my career, I actually came to Ann Arbor in 2009, but about 5 years ago, or as I moved through my career, I kind of made the rounds and did the healthcare systems, and now I'm back, and I've been back in Ann Arbor for the last 2 years, and it's nice to sleep in my own bed. I was kind of putting some notes together and listening to the folks, and I thought, what would they like to know? And I thought, well, maybe I'll just do a little history and then kind of share where we're at right now. The VA, we actually are they're very fortunate because we're such a large interconnected healthcare system, which sometimes has its downsides. It also has its strengths. So when it comes to resources, we really have the ability to kind of create the change and move resources around in support of these type of events. Now, what you don't know is when Hurricane Katrina hit, that's what we refer to as our fourth mission, which is supporting our community. And I was actually sent. So my experience with an event like this has been, you go, you help, you come back, and you have this kind of period and you get to be back into your health system. This is a little bit different, right? This is like, it's here within the healthcare system, it's here in our community, it's throughout our nation. So there's no actually going and coming from, it is everywhere. So when I think of how we're going to manage this, especially from a healthcare community situation, I do worry that it's like there's no place for a little respite, no opportunity to kind of step back. Even right now, as we're stepping back, it's still, there's still that anxiety in preparation for what's next. So I thought I'd take maybe a couple things. The VA, we, when this kind of hit in February, we did a lot of work to get prepared. We tripled our size of our ICU. We did all those things that everybody else did. But then we felt like a person that was all dressed up with nowhere to go. We weren't seeing the number of veterans that were positive. We weren't seeing a lot of those issues. And but we did know that in Detroit, things were getting very stressful and very hard to manage. And so myself and the director in Detroit went forward with Region 2 and some of our other emergency management groups and leaned in and to support the Henry Ford Health Systems, the Beaumont systems, all those systems that were struggling and trying to maintain services. So we actually, something that's unusual is we had people come to us and we brought in a lot of patients. So in addition to managing and meeting the needs of our veterans, pulling down our services, moving to a different format, or we actually do, for example, 90% of our mental health care via virtual. All those things we did in preparation and then the action. we were able to actually bring folks in from the community and support them and support our community partners. I would say we had some lessons learned when we did that. You know, one thing was we were still watching folks struggle and trying to work through the region, and realized that it was going to take a doc-to-doc call and improving the processes in order for us to help and support those folks working out in those different healthcare systems. And so we learned a lot in how to change, how we approach things, how to we spread our community, and really kind of reached out with all of our community partners. So that has probably been the biggest change and adjustment we've had to work through. Folks also know I actually am just now returning after a week of 2 weeks of being quarantined because I tested positive. And so I've also had my own personal experience and how to manage that, and also work with you know, what it looks like on the other side. Other lessons, so where are we at right now? So our healthcare system still has COVID patients. We're looking at what our healthcare system looks like in the future. So traditionally we might have one ICU and a PCU and an ER department, and we're asking ourselves, do we need 2 ICUs? Are we remodeling our footprint in our healthcare system? So that's one of those next steps that I think a lot of the healthcare systems are trying to work through, which is how do we plan to go forward, at least in the next 18 months, if not longer, after this crisis. And I don't think this crisis is over with, but what does it look like going forward, and how do we keep our employees and veterans safe? We had some pretty significant, you know, lessons learned. You know, right now, even to this day, I continually am communicating. We are looking at different ways to communicate with everyone, anyone and everyone, from our community partners, our congressional partners, our veterans in the community, our employees here. It has to be continuous and ongoing. And that's why one of the reasons I appreciate you asking me to come and speak, because I think when you look around in Ann Arbor, or just in different healthcare systems, we're often forgotten. You know, it was funny, even when we watched the flyover, it was flying over University of Michigan and St. Joe's, but we were right in the middle. And so we always kind of think about, you know, how can we be more visible and support our community? So we learned a lot about communications and visibility. Our incident command from an emergency perspective has been run by clinical staff. And I would offer that was kind of new for us. That was a lessons learned. And traditionally in our past, our incident command were more administratively ran. You know, you have a blizzard, you manage it, you go on to the next step. So it was a tremendous learning curve for our clinical folks, and also creating that depth of resources needed to help keep managing and moving forward. I would also say is we also learned that we had to own our mistakes. Mistakes will occur in this. You're not doing it right if you don't have the occasional mistake. It's what you learn and how you work from that. So we had our incident command was hit hard with positive folks, because that was before we learned about to really create more social distancing, to use Zoom meetings and things like that, because they were working so closely together in preparation and action for what was going on in the healthcare system. And so we learned, and we had to learn. We had my nurse executive came back, and she had been sick and she'd been away, and she came back and she started looking at our data. And she looked at it from a different perspective, and she realized we had a hot spot. And from there, we went out and we learned to do what we needed to do in support of our veterans and our employees. But probably, I just wanted to share some of the things we learned. Some of the things that were on our mind right now. You know, we still have, you know, our capacity is increasing. We're working through a recovery plan. And we're asking, what does that look like? What does our healthcare system look like? We moved all of our long-term care patients to Saginaw and Battle Creek. So we are now working more like a market. We can no longer, if we're going to provide the quality of and acute care here, we're going to have to change or remodel what we look like as a healthcare system. What does it look like with our community partners? We've been very fortunate to be financially resourced. So when I look around and I see these health systems that are laying off employees and furloughing and have major debts, really we look at it and say, how can we create some synergy and work together and support, because the healthcare is going to look different going forward, and that's big on our mind. What does it look like going forward? How do we create that change? What are our motivators and drivers, and can we take advantage of this opportunity to remodel, say, for example, continuity of care or management of complex patient populations? From the employee perspective, we were able to deploy internally from our healthcare system about 200 employees. Nurses that were working in different roles were able to team with nurses in the ICU and create and had ICU background and stuff like that. Now they're going back because we've been able to draw down our needs. But the question then becomes, what do we do for them? How does it look for them coming back from, it was like this when they left, they went through this major experience, and now they're coming back into the roles that aren't the same anymore. So we've been working really, particularly right now, working on a plan that allows for management of some type of respite or rejuvenation, but also taking advantage of an orientation. We need to think about how I believe that if we take care of our employees and we're strong and we support them, A, they'll create the change we need to, but B, if this comes forward again, they'll have the memory muscle or the muscle memory to kind of flex a little bit more effectively. But right now we must take the time and push some of those services that we want to get up and running back out a little bit and take this period of time to resource and support our employees. So that's where we're really working right now, is kind of that unwinding, respite, rejuvenation, and reorientation. And then I guess we want to we're also at this point right now as we're working on a recovery plan. What are the guardrails? We've got a lot of guidance from our folks, but what are the guardrails so that we safely do this moving forward for our veterans, for our patients, and for our employees and all of our community partners, so that we have a successful recovery. And there are limited resources, so we're really trying to work with a lot of different folks to come up with approaches to doing that. And then, of course, if you believe the folks out there, we're going to be in a repeat. So what have we learned, so that we're going to take some time to sit back and say, I'm actually commissioning with our research department a survey and interview process to find out what did we learn at different levels of the organization, and then how could we create the change so if we go to a repeat, we're more effective coming out of the gate than we were. We were great coming out of the gate, but could we make it more effective going forward? I don't know if this is what you wanted.
It's fine. It's fine, Ginny. How are you feeling? You said you tested positive. Have you been sick?
I did a couple. It was very much a learning lesson. I actually I had the opportunity to be tested because something was off and was not right, but I never experienced all the symptoms that everybody else has. And so this is disconcerting to me, actually, because from my perspective, I don't think we know all that we don't know. And so right now, with testing being very limited and utilization, and I feel fine. I had I teach my folks care for self, care for colleague, and care for veterans. And so I took the time to step back and let my employees, which I brought on board and created depth to do it, and to get some healing time. So I'm doing very well. I was very fortunate, but it was a little kind of, how did this happen? And right now I tell my folks when I left, I said, I want to be part of the solution, not part of the problem. So I'm going to take some time away. I'm going to do all the right things we need to do. I'm going to let you move this forward because that's what we're working together. But I was very fortunate to have a very mild case, and now I'm part of the solution. I've signed up for our serology testing.
All right, well, listen, take good care of yourself, and be careful, because I'm hearing that there's waves of this, and even after you feel good, you could get sick all of a sudden. So we hope there's a couple questions that we could ask to the physicians who are coming up about what we're learning about the science of this, and it keeps changing. I know we try to keep up on this. So I'm going to switch to one more speaker. Thank you, Ginny, and Dr. Charmaine out there. You out there? Where are you?
Let me unmute myself. There we go.
There you go. Okay, so good morning, and it's nice to meet you first time. So maybe you could introduce yourself, Charmaine, Dr. Gregory, and talk about what you do and what you're experiencing. And also, I guess the question people are asking, what are we learning about the disease as we go along?
Okay, so I will preface the question that was posed about what we're learning about a disease we're going along. It is what I would say today is probably what is not going to be true tomorrow. So it's a true moving target. So I mean, I could tell you like what we've kind of been updated on in the most recent past, but again, it's not something that's going to be concrete for you to be able to move forward with. So, because it's constantly changing, and we really are not at a place where we have true randomized controlled trials, which is essentially the gold standard for research, because obviously we're going through the process. And so everything that we are relying on is essentially based on case studies and based on experiential data. So, so I'll just say that. So who am I? I am Charmaine Gregory. I am an emergency physician, board certified, fellow of the American College of Emergency Physicians. I'm a night shift physician who works at St. Joe's Mercy, Ann Arbor. What has this whole situation meant for myself, meant for my team that works in the ED? Well, it's definitely quite different from anything that we've ever been trained to deal with. And it is different in this way because, number one, it is something that, like I mentioned previously, is a moving target, constantly changing. When we think we are on top of it, something differs and we are led down a completely different pathway. So to give you an example of what I mean. So at the very beginning, we were relying very heavily on symptoms, like, have you had a fever? Is this kind of like the flu? So that's kind of how we were triaging patients and how we were really figuring out who do we need to protect ourselves when we see them or not. And then we found out that there are patients that come in who have other symptoms coming from other body systems, not just the respiratory tract. And this basically put us in a very interesting and precarious position because, as Ginny mentioned, some of us became infected, right? Some of us had to essentially take ourselves off of the care track and stay home and be quarantined and be out of the game. And so this is something that stress is not new to us in the emergency arena. It's not. We are used to that. We thrive on that. We literally function in an environment where there is little data on which to make decisions that are critical to the lives of the people that come through the door. And so stress, not new. However, what is very fascinating and perhaps the thing that is most stressful for those who are delivering the care right now is that, we feel the stress of the unknown. We feel the stress of the changes that are happening. We feel the stress of the potential that any day now we can be infected and then we are taken out of the game and then we are no longer able to provide the excellent care that we are so used to providing. That is a stress that is not covered in nursing school. It is not covered in medical school or residency. And the other component that is perhaps the most much of a heartstring pull is the fact that we know that when someone comes to the emergency department, they are out of their usual environment. They are not in a place of control. They have basically relinquished their ability to modify the aspects of their environment. If they're an engineer, they're not in their role of an engineer. They don't know, like, how can they solve the particular problem that's at hand. Then they come into this environment where they know no one, they know nothing of what is actually going to take place as far as the steps. And then because of this ridiculous situation that we're currently in, they are now basically extricated from their support system. So, you have someone who is used to being in control of what's happening to them. Now they have something unexpected occurring. They're placed in an environment where they are no longer in control of the circumstances. They are taken away from their support, which could be their spouse, their child, their advocates. And then we place them in a gown that is too thin for the climate, and we place them in a room where they don't have someone there to hold their hand and to speak for them. So to me, that is the worst part of this whole situation, because I love to go in and talk to my patients, to basically hold their hands, especially my elder patients, because I have a special place in my heart for my elders. And I love to go in, hold their hand, rub their shoulders, and ask them, tell me your story. What did you do before you retired? That has been stolen. This virus has stolen that contact, has stolen that opportunity to build meaningful rapport in order to get the data that comes from that kind of encounter that allows me to take the best care of that patient. Because oftentimes when we're just asking questions, we don't necessarily get to the meat of the issue to figure out what is truly going on. And that is huge. That is an injury that has happened to us as caregivers. It has happened to the patients because they no longer have someone at the bedside. And if they're incredibly ill, it's even worse. Because before, what we could do is, while we were resuscitating somebody, we could have the family come back and be present so that they can have an opportunity to relay their feelings to their loved one before, something terminal has occurred. That is no longer happening. And so you heard Connie talk about the fact that she wasn't able to be at her mother's bedside during those times when, she really needed her. And so that is happening in our emergency department. And that's really something that is extremely painful for everybody involved. So there's a moral injury, as Stefanie mentioned, that is basically, from the provider side, from the physician, the APP side, as the nurses side. And there's also a moral injury that's happening from the patient side. So, it's bigger than a virus. It is bigger than this crisis. Because what has now happened is that there's now a wall that has been put up between us as physician and patient, that I don't know how we're going to move forward from this to really have meaningful relationships. Yes, we can implement things like telemedicine. Yes, that's great. But there is something about that human touch. There's something about seeing somebody smile, which now you cannot see under the mask. When I go into a patient's room, no longer are they able to recognize me as a person that they might see in a supermarket. Now they're seeing this mask, this goggles, this hat, this gown. They're seeing someone coming in a costume. And that creates angst, rightfully so. And that also creates a barrier. So, so there is that stress, which I completely did not expect to experience. And I see it in the team. I see it in the nursing staff. I see it in the tech staff. I see it in radiology. I see it in the entire team is affected by this. And then the part that is also quite unexpected that we didn't realize is everybody is at risk, right? Because not only are the physicians and the nurses and the techs and the rad techs and the respiratory therapists who are having direct contact with the patients at risk, but we are also talking about the valuable members of our team. And I'm referring to the transporters that take the patients from the emergency department to their testing, that takes the patients from the emergency department to their rooms. I'm also talking about the environmental service staff that makes sure that the rooms are cleaned so that we can have another patient get served in that room. I mean, they're putting themselves at risk. So if you think that we are concerned about bringing this thing home to our families, to our elderly parents, to our, immunocompromised friends, just imagine what they're going through. So I saw that and it really pained me. And so, when you talk about a different kind of stress, like in a way, I almost welcome a patient that comes in and is having respiratory distress other than COVID, and I can deal with that. Give me somebody who's having an asthma attack. I can deal with that. Give me somebody who is having a crisis from their diabetes. I can deal with that. This stress is just very different. Moving targets, so many unknowns. We do our best every single day with the data that we have at hand, with the testing that we have at hand, and we deliver the best care possible. And we have to keep in mind that the ones that are affected the most are the patients, are their families, and then are the ones who are delivering care and are associated with the delivery of care in whatever capacity. So referring again to those that transport the patients, and as well as those that do our check-ins for our patients, our clerical staff, and those who are cleaning the rooms. So this stress is very, very different than figuring out what the diagnosis is and taking an action. So that is what I noticed. And for me personally, as a mom, as a daughter, because I have an elderly mom, you know, every single day that I get home from work, I consider this because I am constantly decontaminating. I mean, we're talking about, you know, I don't wear the same, we don't wear street clothes in the hospital. We basically change into scrubs. We wear full protection when we see all the patients. And then afterwards, decontamination includes, you know, wiping everything that you utilize down. And then before coming into the home, decontaminating again, shoes, everything. And just trying your very best to not bring the virus home to those that you love. And so that is very stressful. And I know that, you know, so the way that I look at social distancing and sheltering in place is very different from maybe how others might look at it. I appreciate the fact that this has been very devastating to businesses, particularly businesses who are, you know, person to person type of business models. I appreciate that. And I really feel like, you know, this is going to be an incredible pivot point for us all. It's a pivot point in medicine. It's a pivot point in business because it's an opportunity. I think someone mentioned this earlier, you know, instead of looking at it in a negative light, looking at it as an opportunity to reinvent yourself, to basically turn what you currently have into something that can be viable in a future state and in the current state. So this is a time, though difficult, that may force us to be innovative and force us to push forward ideas that were outside of the box that maybe we kind of kept tucked away because we were a little bit afraid about how it would fly. And, you know, and so I do appreciate that. And I'm not downplaying that at all, but it does upset me when I go out and I see people gathering, because what that tells me is that we are starting to get very comfortable with the fact that, you know, yes, we're not having as many people die currently. And yes, we're not having as many positive cases currently. But if we go back to what we were doing before, all that capacity that we ramped up for in our systems that Ginny talked about and that we have done in our system, you know, it's going to be for naught. Because then what's going to happen is all of a sudden, we're going to be ramping up all the cases that are going to be coming through the door, and then we're going to just overwhelm the system all over again. So I am very guarded in my my viewpoint on basically how, you know, when and how we should open this place up. I'm just really worried about that second wave, and I'm really worried that we're just going to get comfortable because we have been good and we are not going to be ready for the unexpected and the future.
Well, that's fantastic, Charmaine. I just really appreciate your viewpoint. We could probably pick each of these points and talk for an hour on several of them, but I thank you very much for what you're doing, and be safe. Do you have to isolate when you come home, or how do you do that? You're on the night shift, so it's probably impossible to stay away from your kids all day.
Yes. So thankfully, I have not had to completely isolate. I have had a colleague that tested positive. And so what happened with her was she had to have her children go elsewhere. So her husband and her children went elsewhere, and then she stayed in the home and continued her isolation until she tested negative.
Do they test you as you come through or take your temperature or anything like that?
So every day that we go to work, we do get our temperature checked, and we get surveyed via questionnaire as to
Okay.
how we're doing.
Well, I'm going to go to your colleague, Stefanie Simmons. Steph, are you there?
I am, Rob. Hi, good morning.
Hi, good morning. How are you? Can you, it's going to be a hard act to follow. Charmaine is so positive, so dynamic.
Absolutely. And I learned a decade ago following Charmaine because I took over from her night shift many a time when we were working clinically together. So I just wanted to point out, Charmaine, to you, there were some clapping hands and applause on the camera there. So if you didn't see it, take a moment and drink that in, because a lot of people are very thankful for the service you're providing our community right now. So I am an emergency trained physician. I used to work clinically at St. Joe's, and I've pivoted in my career to lead the relational excellence efforts for Envision Physician Services. So that encompasses patient-clinician communication and patient experience, but it also encompasses the employee experience of our clinicians with the company and how we serve them. So I'm going to speak on a small portion of that role, which is professional well-being of our clinicians, which has become the focus of my work over the past 3 months. We had started to lay some groundwork on clinician well-being in mid last year, and we're about to launch a wellness champion program that included providing substantive peer support for our clinicians when they're sued, when they have a medical error, and also identifying what some of the pain points of practice are, addressing and closing the loop on communication. We finished our first of 15 trainings the second week of March in that program, and then the rest needed to be canceled and delayed, as you can imagine, since they were all in-person trainings. So we pivoted to look at what the actual needs for professional well-being were within the organization, and to use the resources that were going to be used for that program in order to support our clinicians in different ways. So as Charmaine so eloquently expressed, the clinicians are undergoing stresses that are not typical of our usual work. One is the stress that our whole society is facing, right? The social and physical distancing, the having your kids home from school if they weren't homeschooled already, right, is a big change. I'm currently running a high school, middle school, and kindergarten out of my house while working full-time from home with my husband, who also works full-time. So, right, so everybody is facing those stressors, but there are specific stressors to clinicians that increased risk of exposure and the fear that brings of infecting vulnerable family members. Financial instability, which is really for clinicians, this may be one of the first times in their career where they've faced some job uncertainty in terms of hours and shifts available, because even though we have greater numbers of COVID patients, we're very worried that patients are staying away from the hospital, staying away from the emergency department with other conditions that are emergency conditions. And so we're seeing fewer heart attack patients, fewer stroke patients, for instance, and we have fewer patients per shift, and that's very concerning because we're worried that our community is going underserved for that reason. Speaking of moral injury, having to take care of patients in isolation, but also seeing the social inequity of who is dying from this disease and how that reflects the social inequities in our society has been very difficult for a lot of our clinicians. And then just not knowing what the best way to help is for different patients in different parts of the disease and different parts of the disease structure has been difficult. So thinking about what those stressors are and then designing a support system has been the work that I've been engaged in over the past 2.5 months. So I'd like to describe a little bit of what we've put together and then some of the lessons learned from that. On the first day that our company moved to work from home for our non-clinicians who don't have the option to work from home, we set up a daily all-employee support meeting. So for non-clinical employees every day, we meet for a half an hour and we gather, we share community expressions of support, and have a positive psychology or stress management topic. And then we end with a 5-minute meditation. So we also have a corresponding meeting in the afternoon that's just for clinicians. What we found was that while we do have a handful of clinicians who attend the afternoon meeting, the morning meeting has been more popular, and I think it's because it's so much larger. There's a large community of people who attend those meetings that people can sort of ninja into that meeting and duck in and experiencing it without being singled out. So we actually have more clinicians attending our all employee meeting than we do our clinician only meeting. That was also a lesson learned for me, because had always been an assumption that clinicians wanted clinician only support, and that seems to not have borne out necessarily in this time. We also developed and rolled out crisis peer support training for all of our employees. And we did 2 live 90-minute webinars in early April, and then posted that on our internal website for everyone who wanted to experience the recorded training. We had over 600 participants in that training with a goal of having at least 1 person attend from each of our over 900 clinical sites, so that people had some common language to talk about crisis peer support and some really substantive, clear examples on how to support each other and how to be on the lookout for employees, for peers, for colleagues who may be struggling. We're very aware that our clinicians in the Northeast, we have a pretty large footprint in New York and New Jersey natively. And then we also have deployed over 200 clinicians, primarily CRNAs and anesthesiologists, to work in the ICUs at Mount Sinai and hospitals throughout New York and New Jersey. So, we were aware that they were going to be facing extraordinary stresses with the environment that they were in. And so we've developed a comprehensive support system for those clinicians, including daily debrief or social support at their site, recreational support. So we've had, chess checkers, adult coloring books. The People of Walmart was the most popular one, it turns out. So just having something that's fun and that they can have some recreation while they're out there is really been important. And then we have an intensive debrief once they come off of deployment, including a 20-minute conversation with a trauma psychologist who has dealt with military deployments, mass casualty disasters. And then we actually go round robin and people share, what's been the hardest thing for them coming back and what they're doing that brings them joy or helps them in that transition. And then we share the resources, and we're having a mandatory follow-up from our employee assistance program. So a first counseling appointment is actually set up for those folks. We did that process because from experience, from research, over a decade of experience personally, and then running the wellness program for our company, we know that clinicians, while very good at taking care of others, often fall short of taking care of themselves, particularly with stigma around seeking care for mental health. So, our professional societies are working on this, and the Joint Commission actually put out a recommendation just 2 days ago for the first time, asking that hospitals not ask always or ever questions about mental health care with part of the credentialing. So only ask if someone is experiencing a mental health condition that impairs their ability to currently practice medicine. This is to help address the stigma for seeking mental health care among clinicians. And then by having a mandated program that's tied to an experience, not a diagnosis, we actually can provide our clinicians care without them having to disclose that as a mental health care and future credentialing to get over that stigma as well. So we've learned that, you hate to mandate things to people who are already over busy, right, and stressed. But sometimes when it comes to self-care and mental health care, people need permission to attend, right? And that permission can take two forms. One is I have to, or another is I'm here to support my colleagues, right? And while I'm supporting my colleagues, if I happen to get some assistance as well, that will just be an accident. And so it gives people that psychological safety to get help and to be safe in their teams and to be getting that support. So we also, we built a huge wellness section of our internal website. We've had over 1,000 hits click through on our wellness resources. But, one of my colleagues said resource page is where resources go to die. And so we've really had to be proactive in getting those resources out to clinicians. So I'm in the middle of a roadshow to all of our department meetings, sort of starting with our hardest hit areas in the Northeast and then going through actually Livonia as well, one of our local emergency departments that's an Envision site in St. Joe's, Livonia, and going through and making sure that we have those resources really visible to the clinicians who are working in those areas. So I anticipate that we are going to have 18 months to 2 years of increased need for support around professional well-being for our clinicians. This isn't a sprint to have those resources available, but it's really going to be an ongoing need. And I'm just thankful that we were building this infrastructure before this started so that we had some language and some knowledge and some infrastructure to lean on when the time came.
Thank you very much, Steph. And how are you doing personally? You got 3 kids at home and trying to manage. So how are you feeling? You staying healthy?
Yeah, I'm. It's mostly a balance between the croissants and sourdough bread and focaccia and everything that I'm baking for stress relief and the exercise that I'm doing for stress relief, so that when the office opens back up, I don't roll in, on the first day. I have a wonderful partner, and I think like many couples right now, we're balancing the childcare responsibilities between the two of us as he works and I work, and it's been a whole different conversation, I think, for 2 career families across the country on how those responsibilities are balanced and cared for.
Okay. We're going to try to break into groups for 5 minutes here at least, and to give you guys a chance to talk to one another. So Emily, you want to say how that's going to happen? Hey, so I'm going to call on anybody want to speak. Lisa Hardy, you there? Lisa, I see
Yes.
you.
Hi.
Report out. Hi, Lisa.
By the way, everybody
Get
should
on
mute
video.
themselves.
I just really wasn't.
Oh, you're looking beautiful, Lisa. So, okay, you know I can do. All right, so how about Mika? Mika, you had a question. You're a psychologist, yeah?
Oh, yes. Oh, you mean the question I posted on the chat?
Yeah, or whatever you want to report on. What did you guys talk about in the group?
Matthew, you mentioned like a good resource for information with sort of the quick updates. Was that right? Oh, it was Roger.
That was Roger.
Roger,
Slavitt.
I thought that was a great resource. If Roger, if you want to unmute, and then they were sort of asking me how it was being a psychologist, and I was saying the difficulties of like us all having different risk tolerances. So I really wanted to be at the Detroit Field Hospital. My partner wasn't really comfortable with the same level, and so I think all of us navigating different boundaries, especially like Dr. Gregory was saying, in the absence of really clear, solid information. And just kind of the struggles around that. So
what was your question to the group, Mika? You maybe want to
I just any more ways that psychologists or other mental health professionals can be a support or an advocate to people in any other field. It sounds like it's a really diverse, great group of professionals here. And it's a big question that I'm struggling with, but if anyone's like, gosh, I really wish I would see this or that, I would be very eager to hear any ideas.
Charmaine, or anybody want to answer that?
As far as a resource for
How psychologists can be resources.
so I think that psychologists can be great resources in this time, because not only are we dealing with all of the things that have been mentioned previously, like the resurgence of feelings perhaps that you didn't realize that you had now that you are isolated from those that are your support system, to the PTSD that's for sure going to happen as a result of isolation, as a result of potentially being infected, as a result of providing care to those who are infected or ill. So it's going to be essentially a lot of need for this category of professional. And so, but the question then is, how do you get the resource to the masses? Well, we might have to do a big PR campaign and kind of get the word out there that you can see a psychologist via telehealth, perhaps. I don't know if that's what you have engaged in your practice, but telehealth will be a great way, because then you can meet the client in their normal environment and you can get them the assistance where they need it. So yes, there's going to be an incredible need for it. I don't know, we have to maybe think about a good PR campaign to get the word out so people know that it's even existing,
Well,
and what resources are available even here in Ann Arbor that can help the community, because everyone's going to need you, honestly. You know, from those who are dealing with the issue, the virus, to those who are not, to those who are dealing with the new normal that we are currently experiencing, to those who maybe don't even realize that they have psychiatric illnesses or psychiatric problems, to those who are dealing with the depression of being by themselves and not being able to have face-to-face and, you know, touch contact with those who are their support system. So yeah.
I'd love to weigh in
Yeah.
on this question as well. I think there actually needs to be a shift from a reactive to a proactive approach on mental health in our communities, whether that's a community of clinicians or our communities within our organizations or our communities writ large, right? Because right now we either wait until someone is in crisis from a mental health disorder, as Charmaine said, or we rely on individuals to seek care. And we do not have a system in our society where that is encouraged for or rewarded for individuals to seek care. And we certainly don't want to wait until people are at the point of a crisis from a mental health disorder and are landing on the ER's doorstep, right, to get them into mental health care. Always happy to be a backstop for that system in the emergency department, but it's certainly not where we want people to access their care primarily. So we need to start thinking, and maybe you're the person who will discover the best way to do this, of how to proactively develop mental health systems within our organizations. So
one of the things that I'd like to add to that as a psychologist myself is that I think we could use Zoom to do family therapy. And I think that what you're talking about, Stefanie, and what the others are talking about, we could do a lot more to bring people together as a family, even though they're isolated. The problem with some of it is that there's not internet availability. Like, for example, my mother-in-law is in a senior residence. She doesn't manage. She's 98. She moved back to senior residence now because she wanted to have her own apartment. But she's isolated, but she doesn't manage all she could do is Facebook. But we could do family therapy session on Facebook. So trying to do those kind of situations, I think is really important. We're going to keep going for a while, even though the time is actually up. But I think as long as we can have a conversation. Lisa, you're on there now. Lisa, how things have been?
Yeah. And I've actually got a 9 o'clock, but I did want to say, you know, you probably have seen the advertisements, but we are, Blue Cross Blue Shield of Michigan and Blue Care Network, we are covering those services, the behavioral health services through telehealth. And I think some type of promotion on that would be awesome, because you probably we would see more use and maybe more proactive use of those services.
Well, I think it might be useful to pick up one of these sessions, maybe next week even, and talk about that. Talk about psychological services and also mental health services for the patients, but also for as Steph and all of you have talked about the need for everybody in the healthcare system. And I like your point. It's not just the docs and the nurses, but it's the people pushing the carts and cleaning up. And, these people who are making $20 an hour, are really putting their life at risk, and it's not like they're choosing to, they just don't have any options. So the folks that are riding their bus to work, those are exposing themselves. So I think we need to, I like your point. Just to wrap up, I think the point that really struck me, Charmaine, that you made about the pivot, that all of us, this is a societal pivot time. We could go right, we could go left, we could go up, we could go down. And I hope it's not a blue-red pivot, but I hope it's a pivot that makes sense in the sense of empowering us, making us a better society, making us more compassionate toward one another. So I appreciate that. Any other questions, comments?
Yes, we also have to think of our other frontline workers, such as those that are working in grocery stores and essential services that don't have the same tie-in to as our health systems and are maybe not quite as aware. And it's a daunting new thing for them.
Connie, while I've got you on the line too, I also wanted to talk about another aspect of what we experienced in New York City, and that is the rolling PTSD that's going to happen, because people are traumatized at different levels right now. And we saw this in New York, where the survivors were as damaged in some ways because they had survived, and the survivor's guilt and all those kinds of things. So I wonder if you could comment on that, what we could expect in the aftermath of all this.
Certainly, yeah, it is daunting, and people think, well, I'm just weak because this is really bothering me. No, you're normal, but it's really bothering you, and that's expected because this is a weird crisis. And this one is going to be prolonged. SARS, when we had the first SARS virus, reliably had a fever. Now we've got all these other symptoms that we're finding out, and we don't know whether anybody you meet on the street, in the grocery, anywhere you go, is infected or not. So it's going to change human behavior, and probably for a long time.
Thank you.
Can
Any
I,
other
hey
comments?
Rob, can I
Yes.
add to what Connie said? Something, I just did a contact tracing course, and I was sharing this with John, and I think what her point is just really incredibly important, is that we don't know who has it. So for instance, what I learned, that I knew that you could not be symptomatic and you could still be contagious. I had heard that in the news. I understood that concept. What I didn't know until I just did this class is that everybody, full stop, who ends up having COVID is contagious 2 days before they have symptoms. Now I know that things are changing. I know that, that is what I just learned. So the 2 days before any symptoms occur, you are contagious, period. And that's everybody. So that means anybody who says I'm healthy or I feel great today, in 2 days may not. And they may be contagious for those 2 days before they have a symptom. That is a game changer.
It's really important to know. I think the other stories that I wish would get out more is how bad this disease can be for people.
Yeah.
I think people are saying, well, it's just kind of like the flu. There's a piece running in the New York Times today about one of the a 33-year-old staff member of the Times, where my son, by the way, works in New York City, who had the disease and how sick she is. And she's a runner, she's a marathon runner, and she cannot hardly get off her bed 3 weeks into this, and it was just awful. So I think if people understood, when it comes to risk, it's like if you understand the probability, but you also understand the impact. And I think people don't realize that the impact is awful. This isn't like a bad cold for a week or anything. This can really knock you off, and not just dying. I mean, dying is bad, of course, in itself, but it's what it's like just to have the disease, and it doesn't matter what age you are. So I would encourage people to just look at that. I'll try to post that article today, but it's in today's Times, and it's from a 33-year-old. And I think everybody should read that kind of an article. Any other comments? everybody's healthy. If you had any suggestions for next time, let me know what that might be. I'd like to keep these going. It's fun, but it's also very stressful. So anybody who wants to help me out with this, I'd be happy to get some help in terms of putting these on. I want to thank Emily for coordinating this. She's behind the scenes, but Emily, great job again in terms of enabling us to break out into the small groups. By raise of hands, do people like the small groups, even though they were brief? Okay, longer, shorter, more time on that?
Longer.
Longer. Okay, I think what I'll do is make the next week a little bit, go to 9:30, I think, so we could build that in, and maybe people can sign off at 9, but we'll go into the small groups. But again, I want to thank Connie. Ginny, are you still out there? I haven't seen Ginny in a few minutes, but thank you to everybody. Big hand. Okay, signing off, and see you next time.